Hello, and welcome to the Your Only Doc podcast. I am Dr. Shashank. Today we are diving into diabetic ketoacidosis, DKA, the sweet and sour storm. Let's dive in. Imagine walking into the ER at 3 a.m. to find a patient gasping for breath, smelling of nail polish remover. Their heart is racing, their skin is parched, and their blood is turning acidic. This isn't a horror story, it's diabetic ketoacidosis, where a sweet sugar crisis becomes a life-threatening acid storm. Stick around because we're about to dive deep into this dramatic diabetes complication. If you're short on time, here's the quick tour of DKA. First, we'll define DKA, who it strikes, and why it happens. DKA is an acute, life-threatening complication of diabetes marked by very high blood sugar, a metabolic acidosis, and ketone buildup. It usually occurs in type 1 diabetes and sometimes also in insulin-dependent type 2. Common triggers include infections, missed insulin doses, and stressors like surgery, heart attack, or steroid use. Untreated DKA is often fatal, but with modern intensive care, mortality is now around 1%. Next, the clinical picture. Patients with DKA look very ill. They have extreme thirst, frequent urination, and often severe nausea, vomiting, or abdominal pain. Expect dehydration, dry skin, low blood pressure, rapid pulse, and a hallmark deep, rapid breathing pattern that is Kussmaul respirations as the body tries to blow off acid. The breath often smells fruity or like nail polish remover. Mentally, patients may be confused or even comatose if the acidosis is severe. Under the hood, without insulin, the body thinks it's starving. The liver floods the blood with glucose and starts breaking down fat into ketone acids. Ketones accumulate, causing a high anion gap acidosis. Meanwhile, the excess sugar forces osmotic diuresis, huge water and electrolyte losses through urine. Notably, potassium shifts out of cells, so blood potassium may look high even though total body potassium is very low. Management essentials follow a classic treatment trio. First, give aggressive intravenous fluids, usually normal saline, to restore volume. Second, start an intravenous insulin infusion to stop ketone production. Third, replace electrolytes, especially potassium. Check potassium first. If it's low, replace it before giving insulin. Add dextrose to the intravenous fluids as blood sugar falls so that insulin can continue without causing hypoglycemia. Bicarbonate is rarely needed and should be reserved only if pH is extremely low, around 7. We'll cover all these steps in detail, then we'll tackle advanced insights and controversies. Think SGLT2 inhibitor related DKA with normal sugars, fluid type debates, and evolving protocols. Finally, we'll share the top takeaways you can't forget, plus a teaser for next time. DKA is an acute life-threatening metabolic emergency in diabetes, most common in type 1. Key triggers include insulin omission, forgotten doses or pump failure, infection or stress, like pneumonia, UTI, trauma, surgery, heart attack, and medications or other causes such as corticosteroids, SGLT2 inhibitors, alcohol or drug use. DKA can also be the first presentation of new onset diabetes. One classic stat: before insulin therapy, DKA was uniformly fatal. Today, with ICU care, mortality is around 1%. Symptoms include extreme thirst, frequent urination, fatigue, and weight loss. Nausea, vomiting, and abdominal pain are often severe. Signs include dehydration, dry mouth and skin, low blood pressure, rapid heartbeat, and Kussmaul respirations, deep, rapid breathing as the patient tries to blow off acid. The breath often smells fruity due to acetone. Mental status can range from anxious and alert to confused or lethargic if acidosis is severe. DKA unfolds through a chain reaction. Insulin deficiency leads to hyperglycemia as glucose can't enter cells, causing blood sugar to rise. The liver then converts fat into ketone acids that are beta hydroxybutyrate and acetoacetate, which accumulate and cause a high anion gap metabolic acidosis. High blood glucose pulls water and electrolytes like sodium, potassium, phosphate into urine, leading to profound dehydration and electrolyte depletion. Acidosis and insulin lack shift potassium out of cells, so blood potassium may appear normal or high, even though total body potassium is very low. Management follows a structured protocol. Start with intravenous fluids, usually isotonic saline immediately, often giving 1 to 2 liters in the first hour. Reassess frequently and continue fluids to restore volume and perfusion. Begin a regular insulin infusion, typically at 0.1 units per kilogram per hour, once the initial fluid bolus is underway. This stops ketone production and lowers blood glucose. Some protocols include a 0.1 unit per kilogram intravenous insulin bolus first, but this is optional if the infusion rate is adequate. Always check serum potassium before insulin. If it's below about 3.3, give potassium first. Otherwise, add potassium to the intravenous fluids, about 20 to 30 milliequivalent per liter to keep levels in the normal range. As blood glucose approaches target, that is below approximately 250 milligram per deciliter, add dextrose 5 to 10% to the intravenous fluids so insulin can continue without causing hypoglycemia. Bicarbonate is reserved for cases with extremely low pH around 7 and routine use is not recommended. Meanwhile, treat the underlying cause, such as administering antibiotics for infection while managing DKA. A newer concern is euglycemic DKA, where DKA presents with only mild hypoglycemia, especially in patients on SGLT2 inhibitors. These drugs cause kidneys to excrete glucose in urine, so blood sugar may remain deceptively normal even as ketones accumulate. Clinicians must now always check ketones if DKA is suspected, even without high glucose levels. Fluid and insulin strategies are also evolving. Traditionally, large volumes of normal saline are used in DKA. However, some experts now debate using balanced crystalloids like lactated ringers to reduce chloride acidosis. No trial has definitively changed practice yet. Similarly, while intravenous insulin infusion remains the gold standard, some institutions use frequent subcutaneous rapid-acting insulin for mild, uncomplicated DKA. This can spare ICU time and cost, though it's not widely adopted yet. Guidelines continue to evolve. Most now recommend bicarbonate only for very low pH levels, in contrast to older approaches that used it more freely. The risk of cerebral edema, particularly in children, has spurred debate about fluid resuscitation rates. Another area of discussion is insulin transition, where some protocols administer long-acting insulin early to smooth the switch off the intravenous drip. Point-of-care blood ketone meters for beta hydroxybutyrate now allow more precise tracking of DKA, influencing how quickly we can declare resolution. Technologies like continuous glucose or ketone monitors and smart insulin pumps that suspend insulin if ketones rise are on the horizon. Prevention is also gaining focus as many recurrent DKA cases stem from poor insulin access or low health literacy. Programs offering diabetes, education, and support are increasingly seen as vital to care. Key takeaways point from today's episodes. Point 1. Remember DKA's triad: very high glucose, anion, gap acidosis, and ketones. Look for dehydration, small breathing, and fruity breath. Point 2. The treatment essentials. Prompt intravenous saline, intravenous insulin, and potassium replacement, all three, are non-negotiable. Point 3. Always identify the precipitant like infection, missed insulin, and be aware of euglycemic DKA, especially in patients on SGLT2 inhibitors. On to the next challenge. We will dive into the hyperosmolar hyperglycemic state. Make sure to like and follow us on LinkedIn, Instagram, Facebook, X, and YouTube to stay updated. And hey, if you enjoyed this, come say hi. You can find me on Instagram at Shashank_107. Drop a message, let me know you're listening, and share what you think.